Hello, everyone. My name is Teresa Rickard, and I lead practice growth and marketing here at Jones & Roth. And I want to welcome all of the practice administrators and other healthcare clinic team members that have joined us today for our webinar. Before we get started, I want to do just a quick intro to our healthcare team. Our practice advisors here at Jones & Roth provide our clients with a practice success plan that is a year-round offering that provides value to owners and administrators, not just at tax time, but consistently through the year, helping to maximize the operational and financial performance of the practice. We also support the success of the owners themselves through an integrated tax retirement financial management plan. We want to thank our sponsor, Watkinson, Laird, Rubenstein, and their healthcare team of attorneys. Their services to healthcare practices include the complex regulatory environment, and they help navigate the challenges of operating a healthcare practice. So thank you to WLR. And then I finally would like to introduce our guest presenter. Elizabeth Woodcock has become a favorite presenter of ours. Year after year, she comes and delivers what we can expect for this coming year, and it's become a highly sought after presentation. As a speaker, author, and consultant, she specializes in helping physician practices achieve and sustain patient satisfaction, practice efficiency, and profitability. She is nationally recognized for her presentations aimed at improving the business of medicine, and she's also the author of 16 best-selling practice management books. Her extensive education and expertise, combined with her humor and engaging delivery, make her a highly sought after speaker. We're so lucky to have her. Thank you so much for joining us today, Elizabeth.
Thank you. Thank you so much. It's certainly a pleasure to be here and to be part again of the healthcare webinar series brought to us by Jones & Roth. Teresa, I appreciate the introduction. I'm really excited to be able to talk about, I don't want to say this great news because that would imply that it is indeed positive, but it is knowledge. And now that we're, 5 weeks into 2024, I think it's important to kind of think about this landscape ahead of us, what we're going to expect in the coming 10 and a half to 11 months, and as well a peek into the future. I know that I am speaking to practice executives as well as physicians. As an administrator, an executive of a medical practice, a clinic, you work with scientists each and every day, and we want to bring forward evidence because that's how we work in healthcare. And so not only are we going to talk about these important topics, but maybe even more importantly, I'm also delivering the evidence that you can seek to further your education, to inform you about these important topics. Because, for example, if you represent a community health center, there may be particular topics on this list that, well, don't really matter to you. And then if you represent maybe an imaging center or a general peds practice or rheumatology practice, there may be others that you think, oh, this is absolutely critical. So you'll see at the bottom of almost every slide the evidence, the horse's mouth, what are those go-to resources, and indeed you can download our handouts afterwards and be able to seek that information yourself. We're going to start off with a public health emergency, and you might think, well, that was over last year. But interestingly enough, there are some sequela, if you will. There's some lasting opportunities. We won't call them challenges. We'll frame it as opportunities. And then we're going to roll into telemedicine, a little bit about reimbursement, sequestration, that pesky little 2% that the government still takes from providers out of your reimbursement. The quality payment program, CPT 2024 will overview. And then what actually may be more important for the future is a little bit about the landscape. Now, indeed, May 11th, 2023 was the conclusion of the public health emergency. It had been in place since January 2020. It was basically updated each and every time during that 3-year period. And in essence, a public health emergency, I like to think of it as the government suspending its own rules. And so one of the rules that it suspended that was really important to you as providers is that it told the states, hey, y'all, I know you're in charge of Medicaid, right? Because Medicaid is a state payer. We actually have in the United States 50 different Medicaid plans. I know y'all are in charge of that, but because of the public health emergency, we're going to tell you what to do. And we're going to tell you that you cannot release patients. Again, you cannot release patients from your rosters. You basically have to hold the database. The beneficiaries have to remain the same through the public health emergency. And so indeed, that's exactly what we did. And right about Q1 of last year, the states got the signal that, aha, we're giving it back to you, right? The end of the public health emergency, May 11th, 2023. And so y'all need to tell us who should come on and who should come off. And so this was called Medicaid redetermination or Medicaid unwinding. And I've just grabbed a couple of snippets from the major newspapers in Oregon. We saw states all over the country who started to look at whether or not their patients should still remain on the enrollment databases for Medicaid. And indeed, in the United States, more than 16 million Medicaid enrollees have been disenrolled. So of course, what that means is they no longer have Medicaid. And this is a process that has happened behind the scenes, again, behind the scenes. And one of the challenges that we have for that is there have been a lot of problems. And you might say, well, I mean, again, who cares? I mean, obviously we care about these Medicaid enrollees, but like, what does it mean for my practice? And the what does it mean is these patients are coming into your practices because all of this redetermination has in essence been behind the scenes, is that these patients are coming into your practice, many of whom assuming they still have Medicaid, assuming they still had Medicaid coverage. So I think it's a great time for you as a practice executive, for you as a provider to really think about scripting with your team. If you do have a Medicaid enrollee who has been disenrolled because you do the insurance verification and realize they no longer have Medicaid, being graceful, making sure that we really talk to our patients in an appropriate, safe way. I say safe because we don't want a patient who needs care to run out of the office. So how can we talk to our patients? And then very importantly, how can we help our patients if they have been disenrolled inappropriately? Where can we refer them to? How can we assist our patients? So really framing the message with your team, because this is happening all over the country, and making sure that we have scripts as well as assistance we can provide to these enrollees. As you can see, Oregon left most of their patients on Medicaid, but many states, in fact, if you look at Texas, my home state, and Georgia, we actually disenrolled more than half of our enrollees. Very, very difficult time. Now, in addition to the Medicaid disenrollment, the other big impact the end of the PHE had was on telemedicine. Now, when you think about it, like pre-COVID, the word telemedicine, we weren't even like thinking about the word. Nobody even, I mean, we knew about it, but certainly very, very few providers were doing it. And it wasn't because the technology didn't exist, right? I mean, we could have done telemedicine for, I don't know, the last decade, maybe even two. The problem was that our payers didn't pay it. And that includes the federal government. The federal government would not reimburse for telemedicine with very, very few exceptions. The exceptions included the patient had to be not in their home, but in a facility like a critical access hospital. The patient had to be in a HIPSA, which is a health care professional shortage area. And the actual technology, the platform itself, was very specific. I mean, I don't quote me on this, but 0.0001% of Medicare claims before the pandemic were about telemedicine. And talk about being so proud of physicians for so many different reasons. But when the pandemic hit, doctors didn't care if they were going to get paid or not, at least at that moment. All of you, I mean, what an amazing profession, just stepped up and said, we've got to figure out how to deliver care to patients. And the way you did it, in many cases, was via telemedicine. And of course, as we know, we did end up getting paid for it eventually, but we kind of got into a hot mess in 2022 and 2023 as the federal government started to go, uh-oh, we can't go back to these pre-COVID era rules. And so what they did was, because there's so many other things that are happening in Congress, they passed, it wasn't just about telemedicine, it was like a portion of this law that got passed, as you can see, in late December 2022, that gave the government basically 2 years, all the way through the end of 2024. So we're in that year now. It's going to end at the end of this calendar year. They gave us basically 2 more years of being able to be reimbursed for telemedicine. And so I just grabbed you, this is the latest snapshot of Medicare telehealth services. And you can see actually there are 268 CPT codes. That column on the left is called HCPCS, but that is the name of the dictionary that includes CPT codes. So you can see, right, I pulled the 99202s, 203s, et cetera. And what's fascinating about this, and I wanted to point this out, is that during this 24-month period, the government has made some reimbursement permanent for telemedicine. And it does include our E&Ms. So what that means is, again, the impact to your practice is the end of the public health emergency, and even the end of this extension through the conclusion of calendar year 2024 will no longer determine the future of reimbursement. It already is determined. And the future of reimbursement, at least for some services that are marked as permanent, and those do include our outpatient E&M, is assured. So if you're doing telemedicine services and with E&Ms, and you should feel very comfortable, at least for Medicare. And we are seeing positive determinations, reimbursement determinations for many other payers. But as you know, we're not a single payer system. So you do want to check with other insurers to determine whether or not they are paying for telemedicine. So lots of debate about the pros and cons, the benefits and disadvantages of telemedicine. On one side, there's a lot, this is great for equity because our patients don't have to drive, they don't have to pay for parking. But then there's, well, but hold on, a patient has to have broadband access, for example. So that's not equity. And of course, there's this big debate about, well, are we going to get into fraud, overuse, et cetera? So what's interesting is that the government continues to discuss this issue of telemedicine. Again, lots of other things going on in this world that are way more important, but I did want to report that indeed there still is discussion about telemedicine. But the good news is those E&Ms are preserved. So if you are doing telemedicine, and here's an interesting use case that I really, really love is for patients who you might be calling to confirm their appointments, and the patient says, oh, no, I can't make that appointment. Maybe I've got a work call, or, I just I can't drive 45 minutes to Bend. It's just too far. And so I'm going to have to cancel and I'll reschedule. So maybe there's an opportunity to, not be like a telemedicine practice, but to be able to offer telemedicine in these circumstances when you would otherwise have to cancel that appointment and possibly even let that slot go unfilled, which, as y'all know, is like the worst of the worst of the worst. So interesting play with telemedicine. I've also seen practices use like annual wellness visits, especially if they have open slots like tomorrow or the next day. They look at that and they go, hey, you know what? It's interesting because these Medicare patients are due for their annual wellness visit. There's no cost sharing for annual wellness visits. So why don't we actually call them up and see if they wanted to do their AWV? So kind of interesting, right? So maybe there's some use cases, even if you don't feel like it's something you routinely want to offer. There's lots of different nuances, however, when it comes to telemedicine. The states are really, really involved. And you can see I pulled a snapshot, and this does include Oregon at the bottom, where there are reimbursement policies for our different states. And that also affects Medicaid, for example. And you might say, well, where can I get this? The FSMB is really a great go-to resource. It is basically the Federation of State Medical Boards, and they have gathered up all of the policies for each state. So I did want to point that out. They updated, I've pulled the latest one, but certainly keep this bookmarked. Now, if you do telemedicine, I really would encourage you to make sure you get paid correctly for it. And, we just talked about like the 99202s, 203s, et cetera. But really where you want to make sure that you have correct is your place of service code. So your place of service code, as you can see, there's kind of two that we use for telemedicine, 10 and 2. And 10 is telemedicine provided in the patient's home. 2 is telemedicine provided anywhere else. And you want to make sure, if you are doing telemedicine and the patient is in their home, that you use place of service code 10. And the reason you want to do that is because 10 allows you to get the full professional fee reimbursement, while 2 gives you a lower fee. It's typically about 30 to 40% lower because they are expecting to pay a facility charge as well. Well, if you're not a hospital outpatient clinic, you're not billing facility charges. So you want to make sure that you get all the reimbursement that is due, and that is place of service 10. Again, telemedicine provided in the patient's home is going to allow you to capture your full reimbursement opportunity from Medicare. So speaking of Medicare, we did see a little bit of a challenge related to 2024 reimbursement. And because it is the 5th week of the year, you're probably just now getting your Medicare remits in from January 1st dates of service and forward. And you will notice that the Medicare rates are lower than they were in 2023. And that is because the government made a decision for budget neutrality. Basically, that's a fancy way for saying they can't spend more than they have. For budget neutrality, to decline the conversion factor by 3.4%. Unfortunately for us, in the professional realm, we are subject to budget neutrality, while hospitals and other facilities are actually tied to a market basket increase. So basically, their reimbursement moves with inflation, and ours does not. So hospitals enjoyed approximately 3.1% increase in 2024. So overall, the professional fee services reimbursement went down by 1.25%. And the reason that is because even though the conversion factor deflated, we saw some increases in the actual units themselves. I'm calling them units. Y'all probably know what I'm referring to, which is the resource-based relative value units, because that is how Medicare pays us. Now, it's important to note that even though I'm talking about Medicare and you may represent, for example, a general pediatric practice and say, who cares, right? How does this even apply to my practice? Even though we do not have a single payer system, we know that Medicare is considered to be the bellwether for reimbursement. In fact, many commercial payers, in fact, it is actually most commercial payers do pay off of the Medicare fee schedule somehow. They usually use either a percent of Medicare for a certain year, or they use the resource-based relative value scale. And I don't know about y'all, I'm based out of Atlanta, and my market, supply and demand are completely out of whack. We have long wait times for physicians of all specialties. There simply is too much demand for the supply that we have. So I was expecting in 2024, particularly after hearing from physicians across the country, they're experiencing the same imbalance of supply and demand. I was expecting to hear an increase for 2024 for Medicare reimbursement. Why? Because access is being affected because we have too many physicians retiring and not enough physicians coming out of training. There simply isn't enough supply. And so I was really disappointed to read the Medicare Payment Advisory Commission report. This was actually just given only several months ago. This isn't years old. And you can see the Honorable Earl Buddy Carter, who asked the question, hey, is this lower reimbursement that we've been allowing physicians to have, not just in 2024, but for more than a decade? Is this impacting access? And as you can see, the answer is these advisors to the federal government say, nope, nope, it is not. In fact, important findings about access to care is that it is comparable or even better than privately insured patients. A little bit frustrating for all of us, and I think we're going to see some changes to those findings this year. As we come out of COVID, there is just so much demand from patients. I hope the data will indeed catch up to the reality of the market. Now, as I mentioned, there are some changes to units themselves, and we saw a bump up in the evaluation and management codes, which are heavily used by the primary care specialties as well as medical specialties. And so you can see that our sort of top three winners, family medicine, endo, and heme onc. While on the flip side, the codes that are often used by IR and vascular surgery, which are typically or at least commonly combined, they use the same set of CPT codes for their services. Indeed, those codes had their units cut, as well as the radiology specialty of nuclear medicine. All other specialties had between a positive 2% and a negative 2% in terms of changes to their reimbursement. I provided the information herein, and again, you can see at the bottom, there is a source document that gets you right to the actual table itself. So between a -4 and a +3, but most specialties clustered 1, 0, or a +1%. Not all bad news coming out of Medicare for 2024. However, I really wanted to spend just a hot minute talking about the exciting reimbursement opportunities for services that you likely perform already and simply don't get paid. I also like the fact that these services are heavily care team based. Staff, our clinical staff, our nurses can perform many of these services. We don't even have to have our physician performing them. And that's always exciting to really be able to receive payment for the great work that your care team is doing around you. Caregiver training, for example, a wonderful opportunity to be paid not only for connecting with the patient, but also all of the training that you do for the patient's spouse, the patient's caregiver. We're going to talk about the G2211 in just a second. CHI is a really interesting opportunity. Community health integration really talks about making sure that you assist. Well, again, many times we already do this. We're getting paid to assist patients in terms of community resources, referring patients to community resources. SDOH, which of course stands for Social Determinants of Health, really exciting news to get screening paid for. Many of you already do it now. There is no specific framework, no specific screening or assessment tool that the government has you do. Many practices, if they do SDOH screening, use an assessment tool like Prepare. Care navigation services are meant for all different specialties, not just, for example, oncology, which often has a lot of care team resources associated with care navigation, but it's meant for you too. Again, these are all services I would argue that you perform and now you can get paid. So G codes are for Medicare. Typically, the G code will sit as a Medicare only code for 1, 2, or 3 years, and then often move into permanent status if the American Medical Association, which is the author of the CPT codes, if they believe it should be part of the permanent collection of the 10,000 procedure terminology codes that are offered to providers to do. You can see this is a very interesting code. I personally love it. This is an extra payment of $16 for basically, as you can read on the screen, the longitudinal relationship, right? The key is the relationship with the patient. So if you have a relationship with the patient, you're seeing them for an office visit, a 99213, you can actually add on this G2211 code for your Medicare patients, except when you bill a 25 modifier, which of course is separately identifiable service. There is no restriction on specialty. In fact, if you read about this, I've given you again that evidence. Working with scientists, so important, that evidence at the bottom. You'll see that the scenario that at least one of them that they give is actually an infectious disease physician. And the infectious disease physician is working with a patient, really, very importantly, providing medication to that patient, but talking them through actually taking it, right? The compliance, how that relationship. So it's the voice, it's the bedside manner, it's addressing the stigma and making sure that the patient is compliant with their medication regimen. And CMS is actually expecting this year more than a third of E&Ms to be billed with G2211. Hello, definitely an amazing opportunity. And in the future, they're actually expecting to pay out more than half E&Ms with this G2211. 16 bucks, I'll take it, particularly if, again, you already performed the service itself. Now let's get paid for it. So our fee schedule lookup tool is a great way for you as a practice executive, as a provider, to see what you're getting paid. And of course, as you can see, this is for Medicare, but because many of our insurance companies do pay based on the resource-based relative value scale, this is a super easy way to download your resource-based relative value units so that you can, I mean, it's not a perfect system because in healthcare, we don't actually get the prices that we are expected to be paid. It's one of the nuances that we sort of live with because of the insurance system. But this is as close as you can get. It's an awesome resource and it's free. Speaking of awesome resources, one of the things that I love is this Medicare Preventive Services Grid. This is not just for primary care. You can see endocrinology, GI with Hep C screening, IBD. I mean, there's some really awesome services. And indeed, these, by and large, have no cost sharing for the patient, and many of them are telehealth eligible. So you can see this, giving you the URL. And again, if you think, well, I mean, I guess, how could I use these? Remember that use case that I talked about before, which is booking patients appointments who actually are due for these preventive services. Or now the trend, I just heard a presentation yesterday, is when patients are scheduling appointments that we're going actually and looking up. Oh, hey, Miss Woodcock, I see that you haven't had your mammogram yet and you're due for it, etc. So being a little bit more proactive rather than just relying on the patient to remember and give us a call. Oh, sequestration, that pesky little 2% that the federal government takes from all healthcare payments. And because we got a little bit of a waiver during COVID. In fact, in 2022, we were in Q1 not subject to sequestration at all. And then, as you can see in the top right-hand corner, we were in Q2 only had 1% taken out. And so what that did, and I haven't run the numbers, so I can't really understand this, but basically the federal government said, we're going to give you no sequestration for that 6-month period, or very limited, but it's actually not going to end in 2025. We're going to stretch it out to 2030. So you can see on your remittances this claim adjustment remark code. It is CO, which means contractual obligation 253, and it is a reduction in payment, 2%. It's unfortunate, but it looks like it's going to be there for Medicare payments through 2030. I will mention that some practices have had success in getting out of the sequestration for their Medicare Advantage payments because technically the federal government isn't actually the payer, right? It's Humana or Cigna or Blue Cross Blue Shield or whoever is administering the Medicare Advantage or Medicare Part C plan. So just to keep that in mind, that some practices have been successful at negotiating that with their Medicare Advantage partners. We know that the No Surprises Act, or NSA, was really, I think, just not well implemented. And so there was this big IDR, independent dispute resolution process. So in essence, practices, if they gave patients a surprise bill, and this happened a lot in like emergency medicine, anesthesia, as well as more facility-based services like ambulance services and helicopters. Indeed, if patients got this surprise bill, there was a IDR, an independent dispute resolution process, which in essence kind of got the patient, the insurer, and the provider all together and said, hey, y'all people need to solve this. Well, it sounded really good, but it did not go down very well. And so what we are seeing is basically kind of a recapitulation of at least this portion of the act. And we expect in Q1 2024 to hear more about how this is going to go down. So if you're one of those specialties and you are dealing with independent dispute resolution, definitely want to keep your eye on the airwaves for more announcements about that implementation of the No Surprises Act. For our quality payment program, this is the federal government's, I like to call it a voluntold payment program. I say that because it is completely voluntary. You do not have to participate in this, but if you choose not to and you accept Medicare patients, which pretty much all physicians in the United States do. I say that there's a few physicians, of course, who have opted out of the program, but it's very unusual. Is indeed, if you decide not to participate, there is a 9% penalty if you fail to do so effectively. So that's why I kind of call it like, I don't really think it's voluntary. I mean, we're already living on the skin of our teeth here. And to take away you already took away 1.25%, then you took away sequestration of 2%, and now you're taking away another 9%. Hello, that's not voluntary. We got to get this done. We got to do it right. So for 5 years, as part of this program, we have had a little bit of a carrot. If you think about this as a carrot and stick approach. In fact, we've had this little bonus last year. It was given to us for this year. And I should say, if you did well in 2022, if you got actually 100%, you were perfect in the quality payment program. In 2024, you're going to be receiving a bonus of 1.87%. Awesome. So the challenge is that this is the last year of the exceptional performance bonus. So our adjustment of 1.87%, again, that won't be happening anymore. I know it's not a lot, but at least it was something. It is the final year where we were able to earn that exceptional performance bonus. So if you do have to participate in the quality payment program, and let me step back and mention, because only those physicians and eligible clinicians, that includes our awesome nurse practitioners, physician assistants, etc., only those physicians and eligible clinicians that have $90,000 or more in Medicare Part B total allowed charges. Again, that's 90 grand or more, Medicare Part B total allowed charges. You might say, well, I have no idea. Maybe you're a new executive at a practice and you're like, I literally have no idea if my physicians would even qualify for that threshold. You can go on to the Quality Payment Program's website and type in the physician's NPI, National Provider Identification, right? That number that it's kind of like the Social Security number for doctors as well as eligible clinicians. You can type that in and it will tell you, I do or do not have to participate. I'm going to ask you to think about, right, if that exceptional performance is gone, then what's the business case for me? I mean, I've worked with practices that have literally hired staff to do this program. I mean, they've put in a lot of money. There is no more exceptional performance. And so what I really want you to think about is we want to avoid this penalty. The way you know you're being penalized is you're going to look on your remittances. I know they come in electronically, but you can still view them. And you're going to look to see if you have this SARC 237. It will be accompanied by a RARC N807. And I know I'm like speaking alien here, but all of our remittances, if the payment isn't as we expected, they have, basically it's like a code to tell us why we didn't get paid correctly. We sometimes refer to them as denials. And sometimes that's true, right? But we want to make sure we explore. A lot of physicians ask me, well, why do I get these payments denied? I don't know. You got to go look it up. I think about these little codes as like a treasure chest of information. So I can chase down, oh, why am I not getting paid? So if I have to participate, and I know I'm not going to get this exceptional performance bonus anymore, let's at least make sure that we participate successfully. And that does include recognizing that this program changes each and every year. And a good example, because many practices use this, is the colorectal cancer screening is no longer available as one of the quality measures. Why? Because you did it too well. I'm sort of laughing, but not really, is that the government sunsets the quality measures that get to 100%. It basically says, okay, well, doctors did that. Let's bring that off and put another one on. So make sure you watch really, really carefully about the changes in the program. An easy way to like mitigate your risk here is just to apply for an exception. Um, you can apply for extreme and uncontrollable circumstances. That really is how you define extreme and uncontrollable. Maybe if COVID isn't an issue in your community, maybe RSV is, and so you're really spending a lot, or your patient portal went down for 2 months and it's been a hot mess. That is an extreme and uncontrollable circumstance. So might be a great idea to consider it. The nice part about those exception applications is that if you then decide to apply, it actually will knock out that application and will place in indeed the exception. So it's like a kind of a plan B, if you will. Okay, so make sure you get rid of that 9% penalty. And the way you do that is you achieve 75 points. Please do take a look at the program. Again, they've updated it in 2024. There are changes, particularly to the quality measures, to 59, which is basically a third of the quality measures. So please, please, please get those 75 points, but maybe back down from getting 100. If we are in primary care, do a lot of immunizations. Definitely, probably now you're 5 weeks in, so you're very familiar with some of the new immunization reporting, the consolidation of the codes. We have new vaccine administration codes. We're going to now actually get paid to administer vaccines in a patient's home, which is really interesting. We actually saw time ranges. I think this is a positive thing, removed from our E&M codes in the office. And then if you do split or shared E&M visits, and this is particularly in the hospital setting, so like oncology, for example, you may have your nurse practitioner or PA go consult with the patient in the bed tower, and then you come in as the physician. That's going to be your split shared E&M visit. Definitely want to take a look at the revisions there. I like to get this book. It's called CPT Changes 2024. It's like $75, $80 from the American Medical Association, which of course is the author of the codes. It really goes into depth about the changes. I love to get that because it allows me to really be able to read and understand those changes each and every year. We've seen a lot of things change in the landscape. As we know, convenience has become more and more important to all of us as consumers, right? We don't walk into a bank anymore to get money. We don't even carry money anymore. I haven't seen like a $20 bill in, I don't know, 2 years. And we don't like call anybody to get a reservation, a restaurant, an airline. Like we are super hyper focused on convenience. And so what's been really interesting to see is from a landscape perspective, many both early stage companies as well as well-funded public companies are really moving into this space to try to capture convenience. Now, that even includes insurance companies, for example, purchasing, partnering with telemedicine companies. I think one of the craziest combinations was United Healthcare and Change Healthcare. I say that because the mere fact that we in the United States let one of the insurance companies merge with basically the information highway for claims for all insurance companies, all claims for providers and facilities. I literally have no idea how that happened. And you might say, well, gosh, Elizabeth, I'm from Central Oregon, or I mean, this stuff, maybe it happens to these people in Portland, but are you kidding me? What's interesting is these new health insurance and healthcare company plays, this is happening in increasingly our medical deserts. Yes, that's the new term that we all are using now. And basically, it is counties, cities, communities in which there are simply not enough providers. So that's where the Walmarts, as well as these smaller like Dollar Generals, they're really going into. The gap is being filled, but not by traditional healthcare outlets. It's being filled by Walmart. So we're seeing Dollar General, Best Buy Health. Best Buy is a really interesting situation. They bought a nurse contact center before COVID. And then during COVID, they were like, hello, good thing. They not only bought the call center, but they bought a telemedicine company out of the UK. And they have really, in fact, a big portion of their revenue now at Best Buy is through this Best Buy Health that is doing a lot of remote patient monitoring. So who cares, right? I'm in rural Oregon, doesn't really matter to me. But what's interesting is we're seeing a shift between, right, who is providing care and in a way, as medical practices, you're kind of like the downstream, the decisions about where patients go, because how they're being financed is actually happening between employers and insurers or payers. And so, because this is changing, right, as we move downstream, they're in the driver's seat, you're the beneficiary of those decisions. And when those decisions start to change, we will feel it. And maybe a year or two, but big money is involved. And indeed, those referrals for care, where the front door for care is changing as we speak. And I think what I really worry about, and all the data you can see in the top right hand, primary care physician claims dropped by 13%. And I get it, right? There is just not enough supply. And so this front door for care is therefore changing. Our patients are going into ChatGPT, they're going into Amazon, they're going into Dollar General, they're going into Best Buy, and that is the front door. So as that is changing, we and the downstream, we're going to see changes as well. I worry about it because United Healthcare, for example, I mean, look at what happened to their stock during the pandemic. Boom, you can see that 2020 was cruising along a while, and then it just went south. And then, of course, it started to pop up. Why did it start to pop up? Because United Healthcare was like, all right, fantastic. Keep it coming. Pay me the premium, right? Pay me the premium. I don't know about y'all, but pretty much all of 2020, I didn't walk into a doctor's office. I, at least for us in Georgia, we were told like, y'all need to stay home. So I did. I was a good one. I stayed home. And yet United Healthcare, which happens to be my insurer, didn't call me up and say, well, you know what, Miss Woodcock, I know you're at home, you've got these 3 children, and but maybe you don't have to worry about paying the premiums because clearly you're not taking them to the pediatrician, etc. I never got that phone call, and neither did you. And so United Healthcare kept gathering all of this premium dollar, and they weren't paying out anything until about the last 12 to 18 months. And so what's happened to their stock prices, it went steadily up over about a 2 to 2.5 year period. And now United Healthcare is like, uh-oh, we were doing awesome. So how are we going to keep our bottom line? This is what we're seeing across the country. And I guess it's no surprise because the economic reality that we have is that the people who are supposed to pay us, or let's use the entities that are supposed to pay us, have an incentive not to, right? They make it really complex. They don't answer their phones. I mean, y'all know this way better than me. And so what's happening, and the data shows us, is that this is crazy. 15% of claims are denied initially for all services. 15%. So we got to fight because these denials are on the rise. Now, it is my hope that as supply and demand continue to come out of balance, that is, we have too much demand for the supply that we have available, is that the data will start to get into the hands of the insurance companies, the federal government, the state governments, that says, like, y'all, we are losing it. We are losing. You have to pay us appropriately. You have to pay us appropriately because access is now constrained. I do think the tables will start to be turned as we really see the benefits, if you will, of the surge in demand. So what we've done, hopefully you feel more knowledgeable, if not more happy. We've really gone over everything from the conclusion of the public health emergency and what the ramifications of that are, a little bit about telemedicine, feeling comfortable if you do it, that we do have some permanence, at least to some of those services. Medicare reimbursement overall going down by 1.25%, but picking up on some opportunities like caregiver training, like indeed some of these other services, G2211, that may offer some opportunity. And I'm all about making sure you get paid for the work that you're doing. Sequestration, boom, that 2%, making sure we're keeping our eye on the changes to the No Surprises Act. The quality payment program may be coming off the pedal. Don't worry about getting 100%, but making sure you're avoiding that 9% penalty. Little bits of changes to the CPT codes this year, and be on the lookout for that competitive landscape. And I think what worries me the most, and I'll turn it over to Teresa, is these insurance companies don't want all of your patients. As one family physician put it to me, he said, Elizabeth, they want my quickie sickies. And I thought, that's a really good way to describe it. They want your quickie sickies. And what I worry about is all of your other patients. So let's go ahead and maybe have some questions. If we do, really excited again to be able to present this material as part of this awesome Jones and Roth healthcare webinar series. Teresa, I'll turn it back over to you.
Thank you, Elizabeth. Yes, we really appreciate your perspective. This is a topic that can bring up a lot of questions. I want to just remind everyone it's not too late to drop a question for Elizabeth in the questions panel. So let's jump into this first question. Does removal of time ranges for EM visits mean that we can't bill based on time anymore?
Oh, that's a good question. And so that is for your office-based visits. And time is no longer a factor. So it can't be the controlling factor that you use to bill by. If it's all right, Teresa, I'd love to encourage the attendee who asked that question, because I always love when they're coding questions, to not just provide, verbal perspective, because I didn't incorporate the source, the evidence in this presentation. If it's all right, I'd love for that audience member either to reach out to you, Teresa, or to me directly, and let me make sure I provide that evidence for you. Teresa?
Great, great. Thank you for that. All right, another coding question here. Can I bill all of my office visits with a G2211? Elizabeth,
So
I'm not hearing. Oh, there you are.
G2211 is
Great. Just double checking. I couldn't hear you for a second, but please
fantastic.
continue
Yeah,
on.
no problem. G2211 is for acknowledgement of the cognitive load associated with the relationship with patients. So I don't want to say you can bill all of your E&Ms because you really want to make sure that you have that relationship with the patient. That's kind of where it hinges on. But Teresa, I am going to make sure that we just mention again for our audience that each one of those slides, including G2211, has that source to give you more information. So that's going to give you scenarios, more descriptions about using that particular code.
Great, great. And we, our follow-up emails, everyone who attended and just registered will receive the slides and the link to the recording, so that'll be excellent. All right, how about this question? How do we go about challenging Med Advantage plans about the sequestration fee?
Oh, that's a really good question. And something, again, I can provide a little bit more detail about. And Teresa, with your permission, I'll send that to you via email so you can share with the attendees.
Okay.
Basically, sequestration, when you actually look at it written into the law, is for government payments. Because Medicare Advantage are commercial payments, they are getting paid by the government, but then the commercial payer is paying providers, is that providers have been successful at pushing back on Humana, Cigna, et cetera, and saying, hey, we're not even subject to these rules. You're declaring that sequestration, but you're paying us, not the federal government. So it's a little bit complicated, but indeed, I'll provide some information, Teresa, for you to be able to pass along to your team here.
Okay, great. From a big picture perspective, do you have any revenue cycle management best practices or recommendations for fast growing clinics where admin is stretched with limited bandwidth?
Well, Teresa, if you've not heard anything else, it's to think about the complexity of what we just talked about in the last hour. And I'm kind of lucky in that, well, I don't even really have a real job. In fact, I'm actually married to a physician, and we talk about this stuff all the time because he serves as the chief financial officer for his practice. And like, how do we keep up with this? So I really would highly recommend some sort of review services, revenue cycle management, really meeting with advisors like the great ones that y'all provide at Jones and Roth to be able to have that touch point. Am I doing well? Right? Asking the question. And I live by the mantra, data before drama. And a great way to actually get that data is indeed through a review service like the ones offered by your company.
That is true. Our team does revenue cycle management reviews. I'm real curious how many of our viewers of today's webinar are actively using RCM software and things like that. It would be great to get some follow-up poll data from our group. Okay, great. Lastly, can you tell me how I know if I'm being penalized by the quality payment program?
So by the quality payment program, I'm going to refer back to about 10 slides ago where I actually listed that adjustment code. And it's a good, I mean, really, I like to use these codes like a treasure chest, and that it will tell me why I am not getting paid. And so the quality payment program does have an associated code. And Teresa, if you don't mind, I'm going to just go scroll right back to make sure that we get the right code for our attendees. And I apologize for the scroll, but wanted to make sure that I got that code for y'all. And again, it's just a good example of making sure that we are keeping pulse. Here it is, the SARC 237. You can see that's a legislated regulatory penalty. Look at those remits, making sure that at least once a month, you're kind of scanning through those to understand why you are not getting paid what you deserve. That's a great question. Thank you so much. And Teresa, I want to say thanks to our audience. I really appreciate your allowing me to provide this information. Teresa?
We so appreciate you as well. I want to thank you, Elizabeth, for being with us. Thank you to everyone who joined us today. We really do hope you're walking away with a better understanding of what's coming up this year, what's happening right now, and that you found this to be educational for you. Take care, everyone. Have a great weekend. We'll see you next time.